All right, let's talk about renal pathophysiology. So we just finished talking about the liver, and it seems like a really good transition from liver to kidney. And I'll show you some of the examples because they kind of depend on each other. They're both really important for clearing waste and getting waste products out. And if the liver starts failing, a lot of that pressure gets put on the kidney, and sometimes it can be overwhelming. So let's go ahead and click through these. All right, so you need to remember your physiology, your kidney functions, and here's just a short list of the different purposes that are out there. And remember, the kidney's trying to maintain homeostasis and keep everything in balance. It's trying to keep your acids and bases in balance, your electrolytes in balance, your water to solute in balance. It's doing a lot of maintenance in there. Some of the rules you have to remember that is it's trying to filter out plasma. It's taking 20% of your cardiac output and trying to pull as much as it can out of the bad wastes and products to put into your urine. It doesn't weed everything out. 20% of what comes out of your heart goes straight to your kidneys. For an organ that's only 1% of your entire body weight, that's pretty significant, of course, is to clean. But only 20% of the blood that goes through a nephron is actually cleaned. So you have to kind of revisit your physiology and look at that a little bit. And we'll talk about those principles again. But it's basically filtering the plasma, trying to get toxins out like ammonia or uric acid or things you may have eaten that are toxic substances and try and get them out. You have to also remember that the things that are being filtered are all things that are smaller than a protein. Because if it's bigger than a protein, its size won't allow it to move through the glomerular membrane. We'll talk about that just a little bit too. When you take in penicillin, the primary way to get rid of penicillin is to urinate it out. Of course, now we've modified the penicillin and stuck some proteins on it to help it stay in your body longer, so it has to be modified a little bit and broken apart before it can be urinated out. So it takes a little bit longer. And if you've never heard that story, you might want to Google it about the first people that were taking penicillin as antibiotics and what they had to do to make sure they were conserving the penicillin. When you look at these functions, it's kind of like the digestive tract, where there are four really main functions of the digestive tract: motility, secretion, absorption, and digestion. Well, there's really three main functions of the kidney. You've got filtration, secretion, and reabsorption. Those are the main goals. So you filter this plasma first. Then things that don't get filtered appropriately can actually be pumped in. So here you have this filtration membrane, the product's going through the tubules, and then what you didn't pull out of the blood, it gets a second chance because these blood vessels come cruising along and moving down next to the tubules. So you can secrete from the blood vessel into the tubule, trying to push it out of the blood. If you're secreting something, it must be bad for you. And that's the way I always remembered it, is that it's something your body really doesn't want because it's putting energy into getting rid of it. So it's something that's really potentially dangerous. So things like acid. You secrete acids. You filter acids out, and you secrete them because too much acid, of course, is going to be really toxic and very dangerous for your body. It helps you regulate some different ions. We'll talk about how you move things back and forth, like potassium we mentioned in the electrolyte section of the class. But you can excrete potassium. When you're trying to push the potassium out to keep your potassium levels normal so you don't have like heart arrhythmias and irregularities with neuromuscular connections or neuron connections. When you're trying to push that potassium out, what are you also pulling in at exactly the same time? Sodium. Remember, the sodium-potassium pumps, you're doing the exchange. So the kidneys are really important for exchanging things like that. And then reabsorption. So let's say that you filter something. You filter it, it goes in here, it gets filtered through the glomerulus into the tubule. Well, what if you didn't want to lose it? You filter things that are smaller than proteins. So you filter out things like amino acids. Well, you don't want to lose those. You work really hard to find them, eat them, and absorb them. So once they get filtered accidentally and slide through this membrane, then they get reabsorbed or pulled back in. So they go along the tubule and they get pulled back into the blood and then carried off through the system. The same thing with glucose. You accidentally filter this little tiny piece of glucose and then you reabsorb it back in. So reabsorption is really important, like sodium. You reabsorb sodium to help you retain water. These solutes, whether it's a glucose or a potassium or sodium or a whole protein or a whole cell, those things attract water. So when you keep more of those in your blood, you keep more water in your blood. I already mentioned this, reabsorb important solutes. And then we talked about secreting. I don't know why this is down here, but it should be up here. And then it has some endocrine functions. And hopefully you remember these endocrine functions. There are really two super important hormones that are made in the kidney. One is renin. So renin is part of the renin-angiotensin-aldosterone system that helps you maintain blood pressure. And we'll talk about that in a review a little bit too. And then erythropoietin. Do you remember what erythropoietin does? It goes to the bone marrow and helps you to make red blood cells. Right. So erythropoietin, if its final objective is to make red blood cells, The initial problem is actually not because you have too few red blood cells. It could be, but that's not exactly what's being monitored. It's because you have too little oxygen in your blood. So let's say you go up to Colorado where there's very little oxygen in the environment. Well, your body has enough red blood cells, but then what has to happen is you make more red blood cells to pull more oxygen from the environment and get it through your system. So there's less oxygen in Colorado. So your body's way of fixing that is your kidney detects that you have low oxygen. It starts making this erythropoietin that goes to the bone marrow. Bone marrow makes red blood cells. They go to the lungs and pick up more oxygen and make the kidney happy. Everything's fine. So now when you go up to Colorado, you actually have more red blood cells than you normally would because your erythropoietin comes out. And this last one, the kidney doesn't make vitamin D, but it does activate vitamin D. So you should remember the pathway of how to make vitamin D, which brings me to the next point. So when you're thinking this, you should still be thinking this process. And I talked about this all the way back at the beginning. With pathophysiology, you have to think of the processes. It's not pathology and anatomy where I say this is broken and this is what it looks like. It's more like this is broken and this is why it broke. And then I also like to show you the pictures of what it looks like so you can see the outcome. But you need to think the processes. What started it all? What's the mechanism of why it's breaking? So if I were to do something, whoops, I don't know why that sun's there. It should say your initial stimulus right here. So you have an initial stimulus, something that's happening. Your body detects that stimulus, and it creates this chain reaction where, let's say, maybe one hormone's made, which triggers another hormone, which triggers another hormone, which triggers a cell to do some final physiological effect, which is some kind of physical phenomenon, right? So you may have a chain reaction. And the example that I want you to think of right now is, since we're talking about vitamin D, let's talk about the sun. So the sun comes out. The sun hits your skin, and the skin starts producing this precursor to vitamin D. It's not actual vitamin D yet. It's a precursor to it. So it's not working. Well, then that has to go over to the liver, and the liver takes the next step to activate it, but it still doesn't work. It's still not the functional vitamin C or vitamin D that we're familiar with. So then it goes from the liver over to the kidney. And the kidney makes the final step of converting vitamin D. So now I've taken what? Sun, exposed to skin, there's 1 step, 2 step, 3 steps to activate vitamin D. And it still hasn't even done its job yet. So now vitamin D, what do you know vitamin D is responsible for doing? It helps you absorb what from your GI tract? Calcium. So this vitamin D goes to the GI tract and absorbs calcium. And then calcium goes through your blood. We know a lot of the effects of calcium, but what's the first thing that you usually think of when you think of calcium? What structures in the body? Well, bone. You know, we could think about it being important for helping maintain muscle contraction or heart rhythm, or we could think of it as being there for releasing neurotransmitters, but most people are automatically going to think of what? See if you can read my mind. Right, bones. So this is the pathway. This is normal physiology. Sun to skin, skin sends the chemical to the liver, liver sends the chemical to the kidney, it activates, it goes to the GI tract and brings in calcium to make strong bones. Well, what would happen if I broke my kidney? What would happen to my ability to activate vitamin D to its last step? It wouldn't work. So what's going to be one outcome of having a broken kidney? Weaker bones. Possibly breaking the bones. So you might be thinking osteopenia, and osteoporosis is an outcome eventually. Somebody that's chronic renal failure, you're going to see their bones weakening. Right? So think of that pathway. Well, what if the kidney's healthy, but the liver goes out that we talked about last week? Exact same outcome. Right? What if they don't get enough sun? Well, there's nothing to go to the liver, nothing to go to the kidney, nothing to go to the GI tract. Exact same outcome. It doesn't matter which step of the process you break, you get that outcome. So always think of the pathways and the possibilities. You can always work backwards too, and you think of, well, if my bones are weak and they're breaking, more frequently, what could be the problems? What does your bone need to be healthy? It needs calcium. It needs phosphates. It needs those osteoblasts to be working. It needs some hormones that we'll talk about later, like calcitonin. Right? So there are a lot of important factors. Once you see those first symptoms, then you can start working way backwards. Well, maybe there's a problem with the GI tract. Maybe there's something wrong with the kidney. Maybe there's something with the liver. Maybe there's something wrong with the skin. Work your way backward or forward. And we talked about the very first day of class, or I guess first lectures, when I talked about pathophysiology helps you to understand or predict the outcome as well as find the cause. All right, let's talk about renal anatomy. And the reason I brought that last slide up now is because when you go through the anatomy, I really want you to pay attention to why this anatomy is significant in the physiology. So what is it about the anatomy that allows the physiology to work? And what happens if you break the anatomy? What if you break the physiology? So let's talk about first the location of the kidneys. And you can see the kidneys, they sit retroperitoneally, so they sit at the back part of the abdominal cavity. They sit right along the back wall. That's what it means to be retro, back, right? And then peritoneal, around the peritoneal cavity. When you look at the location of the kidneys, the right one sits a little bit lower than the left. Why? Well, what organ is pushing down the right kidney? The liver. So it's pressing down or compressing on it. So what might happen if somebody has like a fatty liver or cirrhosis of the liver and they have a very inflamed, enlarged liver? What could happen? You could compress this kidney. You might see some kidney effects. We talked about the hepatorenal problems in the last section too, so we'll come back and go through some of those. But when you look at the location, the significance of the location is really important because of things like pain. So you want to think of the pain, since it's a common symptom of kidney or basically urine or the pathway. Urinary pathway. Whew, been a long day. When you look at the pain, if it's directly in the kidney, usually it refers to the back. They have this diffuse, deep feeling pain. Well, what if there's damage to this ureter coming down? Well, usually it's a little bit lower in the lumbar region. Well, what if it's in the bladder? Well, then usually it's more in the abdominal pelvic region. Right? So you can tell the location a little bit based on where the pain's at. So is it sharp shooting pain? Is it dull achy? Is it more towards the front, the side, or the back? So a lot of these hints give you ideas. So pain is one of the symptoms you have to keep in mind. Like the prostate. Cystitis is talking about having an inflamed bladder. So of course the pain is going to be more at the front and towards the pelvic region. Even obstructions. You want to remember with referred pain. So if you have referred pain and it's in the kidney, usually it refers right to the back area, or sometimes it'll actually refer towards mid-shoulder blades. They feel the pain up there. Second, you want to be familiar with the renal blood vessels. The vessels going into the kidney as well as the little tiny ones. So definitely know your terminology. If it's going into the kidney, what is it? Efferent or an afferent? Right? It's efferent, afferent? It's an afferent. What about the blood vessels? If it's going in, it would be what? An artery or a vein? It's an artery. So the arteries go in, they break down into smaller vessels, and then those afferent vessels actually go into these structures called nephrons. And the nephron is the actual functional unit of the kidney. And we'll talk about that in a little bit more detail. But remember the blood flow. What if you have an aneurysm or you have atherosclerosis? What if you have an obstruction of the blood flow going into the kidneys? Well, it's going to make a huge difference, and I'll show you some of the symptoms of that actually right here. So renal blood flow, your kidney gets about 20% of all the blood pumped out of the heart in one heartbeat. That's 20% of the cardiac output. And I already mentioned before, that's for an organ that's only 1% of your body. That's very significant. Well, there are two things you really want to remember with the renal blood flow. One is that renal blood flow, the blood flow going into the kidney, helps you regulate your filtration rate. So the more blood flow going in, the more blood you're going to filter, which means you produce more urine, you get more urine output. Right? So if you turn down the blood flow to the kidney, you're going to retain more of those fluids. What's it going to do to your blood pressure? It's going to increase your blood pressure, right? So you can kind of predict some of these things. But when you're talking about renal blood flow, changes in renal blood flow, you want to think of GFR, but you also want to think about that the kidney depends on this blood flow going in too. So the kidney's depending on you putting blood into them to keep them alive. So if you have very little blood flow going through the kidney for an extended amount of time, what's going to eventually start happening to the kidney? It's going to starve, it's going to atrophy, and it could potentially die. You don't want that. The kidney is way too important. You don't want to decrease the circulation for too long. So when you look at the control going into the kidney, of course it's there for nourishment, it's there to help filter, but how is it regulated? Well, the kidney can do some autoregulation through something called the tubuloglomerular feedback mechanism, which we talk about in physiology, and we'll talk about again here in a couple slides. So there's a feedback. The kidney to detect the blood flow going through and adjust it accordingly. There's neural regulation. So the brain, of course, is out for itself. If the brain needs more blood flow, one of the first organs that are going to take a hit are the kidneys. The brain will send signals out, so you get the sympathetic signal going down and out to the kidneys that tells the blood vessels going into the kidneys to do what? If the brain wants the blood, what are they going to do to those blood vessels? Your brain's going to constrict the blood vessels, redirect it up towards the brain, and starve the kidneys. So unfortunately, neural regulation can out-control autoregulation. So if the brain is dying or starving, it will tell all the blood go up to the brain and forget the kidneys. It ignores them completely. And these are just the sympathetic pathways if you were wanting to go back and review. And then hormones. So you have to remember that renin. So we talked about it before just briefly. That's really important. It's made by the kidney release, and it helps regulate your blood pressure. And it'll come up again. And then catecholamines. So catecholamines can be circulating through your blood too. It doesn't have to be necessarily going through a sympathetic neuron. And if you don't remember what a catecholamine is, think epinephrine, norepinephrine. Those are catecholamines. Right? So usually when you're adjusting renal blood flow, you see symptoms that are related to urine, the frequency. So if you have more blood flow going to the kidneys, you put out more urine. If you have less blood flow going to the kidneys, you put out less urine. If my blood pressure drops, and this is actually what this is over here, if you see changes in the blood pressure, what if your blood pressure goes down? So blood pressure goes down. What's your brain going to think of that? Your brain's going to freak out. It's going to tell the kidneys what? Increase blood flow to the kidney or decrease blood flow to the kidney? Well, it's going to say decrease blood flow to the kidney. So if your blood pressure drops, you're going to vasoconstrict the blood vessels going into the kidney. Why would you do that? You redirect the blood to the brain, right? Why would you also slow down the flow through the kidney? So it gives you a better chance to do what with the water? Reabsorb it. That water goes into the blood and causes blood volume increase, which causes blood pressure increase, which corrects the problem. So that's just one function. Here you can see also the kidneys. When the kidneys detect a drop in blood pressure, they release renin. Renin goes out into the system, and there's that whole renin-angiotensin-aldosterone mechanism. Right? So it goes out. It sends a pathway over to the adrenal gland, and the adrenal gland releases aldosterone, which goes to the kidney and tells it retain salt. Well, if you're keeping salt, what do you start keeping? You keep more water. Your blood volume goes up because you're keeping more water, increasing your blood pressure, and you have this loop again. Right? Hypothalamus will also, remember, stimulate chemicals like ADH, antidiuretic hormone. ADH goes to the kidney and it helps you retain water. Same idea. Causes blood volume increase, causes your blood pressure to go back up. So you can follow this mechanism over and over again. You can see the pathway. Right? So there's a lot of regulation going on in the blood to help maintain things like blood pressure through the kidney. In nephrons, you have about 1.2 million per kidney. Remember, you can live without one of the kidneys as long as the other one's good and functional. The functional unit of the kidney is the nephron. And then you have two special types. You have cortical, which sit primarily up here in the cortex. So here's the renal cortex. There's the medulla, if you don't remember. So you have some short nephrons. And then you have the other ones that are juxtamedullary, which go way deep down into the medulla. These are the ones that are better at actually conserving water and adjusting concentrations of water. So when the nephrons start dying off, they don't grow back. They're like a neuron. Once you kill them, they're gone. Your kidney, you can lose one complete kidney and not have any problems with your life. It still has the function of, about 80% of the function of two whole intact kidneys. This kidney will actually become a little bit hypertrophic and enlarge a little bit just to get bigger to help handle that filtration process. It's when you get close to 25% of the total capability that you start seeing problems, major problems. So your kidney, as we age, just keeps decreasing function. It's when it gets severely low that we start seeing symptoms. So there's another point. I'm putting these in highlights because I really want you to remember them. All right, when you look at the nephron itself, here you have the blood flow going in, blood flow going out. Then you have this little area here called the renal corpuscle. Right? So if you remember, this is the glomerulus. Actually, I'll just look at this picture. So blood flow going in, there's the glomerulus. Here's Bowman's capsule. These are collectively known as the renal corpuscle. Right? If we zoom in and look at the glomerulus' primary purpose is filtering the blood. It's for filtration. If you look, it has several layers. Here's the blood flowing in the lumen. As it pushes through, you can see all these little tiny pores are called fenestrations. And these little pores are actually blood vessel lining. So some things can seep through. But then the next layer is kind of a cottony thick layer right there. So there's the blood vessel pores. Then you have this cottony thick membrane full of glycoproteins or sugar proteins. It's almost like putting terry cloth underneath of a spaghetti strainer. You can dump water into the spaghetti strainer and things will slide through, but then you've got the terry cloth underneath to kind of slow the flow and also help filter things better. And then once things go through that terry cloth, then it's almost like you have another strainer underneath. And these are called podocytes. And the podocytes are foot cells. And they have little openings called filtration slits between them. So things can slide all the way through, but not everything. Most particles that are smaller than a protein slide right on through with ease. It's the big things that are as big as a protein or even groups of proteins like cells that can't slide through. So if you have damage to the renal corpuscle, what symptoms might you see? What if you damaged this? What if I punched a hole right through your spaghetti strainer and then I dumped product into it? What would happen? Well, you wouldn't catch things. So you might expect to see proteins sliding through. You might expect to see red blood cells sliding through. Other structures sliding through that shouldn't normally slide through this membrane start getting out. And that would be one of the symptoms if you have damage to the renal corpuscle, or specifically to the glomerulus. And we'll talk about diseases related to that too. Okay, next one, the renal tubules. So the tubules are what are carrying what we call filtrate. It's pre-urine. It's not quite urine yet. So here you have the glomerulus again. And these are kind of cool because these are actually pictures of the glomeruli all over the place. And then the glomerulus filters things out and it dumps it into Bowman's capsule. As Bowman's capsule's moving this fluid along, it's trying to reabsorb things that are really important. So remember those processes? You have filtration first, then reabsorption next. Right here in the proximal tubule is where you reabsorb most of the things you're going to reabsorb. Right? This reabsorption process is energy dependent. It depends on ATP. So whatever you're trying to reabsorb must be really, really important. And you're going to reabsorb things like sodium, some potassium, some phosphates, as much glucose as you possibly can, as many amino acids as you possibly can. Anything that was important to your body, you're going to try and reabsorb as fast as possible. Right? And you can see here you have this brush border, just like the GI tract. That's ideally, it's rough and it's increased surface area, so it's ideal for reabsorbing things or absorbing. And here you can see the process of absorption. So here would be the tubule lumen. And you're trying to move things across and get them into the blood. And that's what this just looks like. So you're absorbing things like sodium, and sodium pulls glucose with it, amino acids with it, pulls phosphate with it. Of course, you know that sodium-potassium pumps, when it's moving sodium in, it usually kicks potassium out. I don't know why I said usually. It always, if it's a sodium-potassium pump, it kicks potassium out. But you can see sodium's really important for moving things. About 80% of the energy that goes into your kidney staying alive is actually for pumping sodium. Because when it pumps sodium, it brings other things with it too. Right? So you've got these transporters there, these little machines that depend on ATP moving things back and forth. And then when you look at the loop of Henle, this is the long loop that's important for concentrating urine or diluting the urine. So modifying the urine basically. This side's permeable to water, this side's not. Okay? This side's impermeable to sodium, this side's permeable to sodium. So water moves here, sodium moves here, but not the opposites, if that helps you remember. So once this has all been modified, kind of cleaned up a little bit, it gets out here towards the end called the distal tubule and then the collecting duct. Usually when you hear about these two, they're pretty much called the same because what happens in one typically happens in the other. And this is an important place because this is where you can modify your sodium and your acids. So if you've had too much sodium going into the filtrate, you can suck most of it back up here. So well, I shouldn't say most, about 8% of what you put into the tubule can reabsorb here. The other roughly 90% is reabsorbed here in the proximal tubule and then down here in the ascending limb. And then things like potassium. And remember, when you see potassium move sodium move one direction, potassium moves the other. Right? It helps you modify pH here, so you can kick out acids here. That's also an interesting thing. As you kick acids out into the environment, you actually pull potassium back into the blood. So there's a trade-off. Potassium's kicked out of the body when you pump sodium, but potassium's pulled back into the body when you're kicking out acids. So it's a neat little balance. And the cells that do that are called principal and intercalated cells. And the principal cells, they primarily regulate sodium, potassium, water, where these intercalated cells primarily regulate potassium and acids. H+, right? And then the symptoms, if you have problems with the tubules, the symptoms are usually revolving around electrolytes and waste imbalances. Like, for instance, you reabsorb sodium. What if your tubules are broken? You don't reabsorb sodium, so what would you see? You'd see more sodium going out into the urine, less staying in the blood, which would cause water to go into the urine, which would cause you to be dehydrated. So kind of think about those electrolytes, and if you have to go back and review the electrolyte chapter, go nuts. Right? I put a little slide in here that helps you remember what things are moved and where. So filtration here at glomerulus, proximal tubule is where you get primary reabsorption of all of these things. So yes, urea is actually reabsorbed. So urea is one of the more abundant molecules in the urine, and it's also about 50% reabsorbed. And we'll talk about urea as we need to in just a bit. And then the loop of Henle, remember water can move, but salt can't. Over here in the distal tubule, salt can move, but water can't. Sorry, I said that wrong. Sorry, the descending loop of Henle, water can move, the ascending sodium can move, but not vice versa. And then the distal loop, or the distal tubule, here's where you start modifying at the end. All right, and then the collecting tubules where you try and collect the end products. Homework number 1, explain the cause and symptoms related to the kidney. So I've gone through some of the symptoms. Now I want you to go back and think about them. A couple of these you have to put some thought in. You might want to look it up. But so why do you get flank pain? Right? Why do you get anemia? Why do you get hypocalcemia in this situation? Go back and look at that last slide. Maybe that'll help you. Why hyperkalemia? So when your kidneys are failing, why do all these things start happening? Why might you get proteinuria? I mentioned that one too. Why might you get acidosis? All right, next. So concentration dilution of the urine is through a process called countercurrent exchange. Countercurrent exchange uses this blood vessel structure called the vasa recta. It goes right along with the loop of Henle. So as things are being pulled or brought into this interstitial fluid, they can move right into the vasa recta and be carried off into the system. It makes it perfect because it allows you to concentrate or dilute, depending on what you need, the urine here. So if you need to have more water in your body, you can actually move more water into the interstitial space and into the blood and carry it off to the body. If you need to lose more, you can actually lose more in this situation. So it helps balance it. The longer the loop of Henle, the better you can concentrate or modify that urine. So this mechanism that monitors that. Now you've got all this pre-urine that's gone down along the tubule. As it's coming back up to the end of the distal tubule, it goes right past the glomerulus again. This is really an important area. It's called the juxtaglomerular apparatus, and it has this mechanism called the tubuloglomerular mechanism. So what this is a control mechanism. As blood's flowing in, these blood vessels have cells around them that help regulate blood flow. So if there's too much flow, they squeeze the smooth muscle, vasoconstrict, so that the flow doesn't go through too fast. Right? And there are actually these things called mesangial cells that are around here. This is a blown up version of the glomerulus. The mesangial cells, here you can see the blood going in. Whoop. Mesangial cells are surrounding it so they can squeeze and compress and adjust the blood flow. So if I'm losing too much water, I just squeeze off this blood flow and not as much water is lost out of my body. Right? All this is just physiology review. Right? Other structures, along here, you actually have things called granular cells. And these granular cells, if the pressure is too low, they'll actually dump something into your system called renin. And this renin, when it's released, adjusts your blood pressure to raise it. If you ever see a hormone like renin and you know the final outcome is to raise your blood pressure, well, what's going to cause it to be released in the first place? Low blood pressure. Right? So just understand your pathways. Right? And then the last cells are right here along the tubule, and they're called macula densa cells. And these macula densa cells, those are important for detecting the concentrations of the urine. So do you have enough salt in it? Do you have too much salt in it? Do you have enough water? Do you have too much water? They determine osmolarity. They adjust how concentrated your urine is. If you're putting out really watery, dilute urine, then what they might do is say, whoa, we're losing a lot of water. Maybe we should slow down just a little bit and reabsorb some more of that water. Well, if you're losing too much salt, if you're pushing too much salt out, that can be a bad thing. They'll say, well, let's slow down the blood flow here. We'll slow down the movement and give us more time to reabsorb things. So those are really important cells that you have to get familiar with or refresh your memory with. Right. So here are some more endocrine cells. You have cells in there. We already talked about renin being a hormone, so that's an endocrine. But you also have peritubular cells that release something called erythropoietin. If you remember, erythropoietin is released because of low blood oxygen. The erythropoietin goes out into the blood, goes to the bone marrow, causes red blood cell production. The red blood cells go all the way back up to the lungs, pick up oxygen, bring oxygen to the kidneys and tell the kidneys, you did a good job, stop making erythropoietin. This is what a lot of people will blood dope with, like in athletes, so they get more red blood cells and they can carry oxygen and they can actually do longer endurance runs and stuff. Right. And we already talked about this, converting vitamin D to its active form that happens in the proximal tubule. Urodilantin, this is really important because this actually inhibits sodium and water reabsorption. So it kind of works against aldosterone. Urodilantin works on the distal and collecting ducts and it says, whoa, we've got way too much blood pressure. Let's go ahead and get rid of some salt. Let's get rid of some water, and we'll bring our blood pressure back down. And then the granule cells, I already talked about these. They release renin. So I think those are the major endocrine structures. When you look at renin too, you have to know this renin-angiotensin-aldosterone system. Talked about in electrolytes. I'll probably talk about it again when we talk about blood pressure. It's right here for you to review. Remember the pathway. Right? In fact, when you get into pharmacology, they'll talk about these things called ACE inhibitors that shuts this pathway off. It's just like pathophysiology. You've got this mechanism, and if you shut one step off, you never get the final outcome. Right? So here they give an ACE inhibitor. This pathway normally raises your blood pressure. By giving an ACE inhibitor, it lowers your blood pressure. It stops your blood pressure from raising, which effectively causes lowering. Right? If you like looking at the pathways, I found this for you. It's a nice flow chart that goes through all the mechanisms of regulating what's happening in the kidney. So if you have low blood pressure, here are all the pathways that will turn on. So here's what happens to smooth muscle. If you have low blood pressure, smooth muscle squeezes. It slows down flow through the kidney so you can reabsorb more water, raising your blood pressure. Here's that tubulo-glomerular mechanism. If you if you need to raise your blood pressure, you'll start releasing chemicals that are vasoactive chemicals that cause constriction. Renin-angiotensin pathway, here it is. It was on the last slide too. And then neural controls. If you have low blood pressure, the brain sends a signal down. This stimulates the sympathetic nervous system to constrict those blood vessels in the kidney, slowing blood flow through, giving more time to reabsorb in the kidney. The nephron itself, there for glomerular filtration, which we've already talked about, and every day you filter about 180 liters of fluid. That means about 92-liter bottles of fluid move through your kidney filtered every day. Of course, you don't urinate that out. You urinate out about 1.5 to 2 liters, so only one of those 2-liter bottles in a day. The rest of it has to be reabsorbed or brought back in. And when you look at these processes, there are movements, and I know in physiology a lot of people hate this, but these pressures against water. One's your blood pressure pushing water out of the glomerulus and into Bowman's capsule, trying to push it through the system. Another pressure is actually the proteins inside your blood. So if you look down here, you've got proteins floating in the blood. Should they be able to move to Bowman's capsule? No, they stay in the blood. Protein is a solute, so what is it attracting? It's attracting water. It helps hold water in your blood. So these proteins in your blood help hold water into your blood and decrease urine output. Well, if you don't have a good functioning liver and you can't make these proteins, that's why you start losing more water into the kidney and you start urinating out more, right? It's also why you start losing more water to the tissues and you get edema with liver failure. So those proteins are really important. I know I've mentioned them several times. And then another force is when water starts filling up Bowman's capsule, it tries forcing itself back in. It's trying to push back in and squeeze in. So as you start filling up your kidney too fast, it'll try and resist and push water back into the blood. And those are the major forces. There's one force that's not mentioned in your book that I can't believe they left out, but proteins in Bowman's capsule. Well, think about it. Why did they leave it out of the book? Should there be proteins in Bowman's capsule? No, because your glomerulus doesn't let protein slide across. However, in a diseased state, you could have protein in here. So as protein slips into the Bowman's capsule, what's it going to do with water? Will it repel the water and push it back into the blood? Or will it pull the water into Bowman's capsule and create more urine? It pulls. When you put more solutes in Bowman's capsule, those solutes pull. It has an osmotic pull or an oncotic pull that pulls water into the space. Well, then that water gets pushed into the bladder and out. So think about it this way. If you're making lots of sugar and eating lots of sugar and putting it in your blood, that sugar slides across. What's it pulling with it? Water. So as sugar and water come into the kidney, you start pushing it through faster and pushing it into the bladder. You make more urine faster when you have too much sugar in your blood, which means you have to pee more. Polyuria, right? You're losing lots of blood sugars into the urine. What disease is that associated with? Right, diabetes mellitus. So make sure you remember the kidney and the different functions and the different forces. And I kind of talked about this before when we talked about electrolytes, but you can, again, go back and review. All right, and then creatinine, we're going to talk about a little bit more in a few slides. But creatinine, excuse me, it's a good marker of how well your kidney's filtering. And you know what? Actually, in fact, I'll come back to this picture because I want to talk about creatinine on the next slide. So when you're looking at these movements or these forces, these forces, anything you change in here actually affects your filtration rate. So symptoms and affected glomeruli actually affect your filtration or your glomerular filtration rate, which also affects the rate that you make urine. So it also affects frequency. Think of the pathways. This is a really tough concept for some people, and it's called plasma clearance. So plasma clearance is actually talking about the amount of plasma that you're filtering of a substance. So it's not the substance you're measuring, it's what you're actually trying to do is determine what's happening in someone's kidney by measuring a substance that gets filtered out of the plasma. And that's called plasma clearance. You're trying to measure the amount of plasma going through. All right? So here's kind of the concept, and this is my best way of making it a little bit easier. If you have, let's say, you have something going through your kidney. Here's your stream going through the kidney. And you start dumping it in. You start spilling it into the glomerulus and into the tubules going downstream. Well, that's filtration. When you're trying to pull things back out, that's called reabsorption. When you're trying to push things that weren't in the tubule and they didn't get filtered into the tubule, that's secretion. They're your main processes. Plasma clearance is trying to determine what's going on with these processes. How efficiently are your kidneys working, in other words? So with plasma clearance, let's say I spill a bunch of these little oranges into the river. Right? I didn't want to spill the oranges into the river. So I have a friend that stands downstream and he starts pulling them back out. He's reabsorbing them from the river and pulling it out. Well, the speed that these get filtered or go into the water, this is called my filtration rate. Right? If this guy takes a break, he's not doing anything. Whatever gets dumped in here is going to come all the way downstream and it's going to actually be lost in the ocean. Right? So if there's no reabsorption happening, then all these products keep going downstream and I can measure them down there. If there's no reabsorption happening and there's no secretion happening, whatever gets filtered is lost. In that situation, we say that the clearance is equal to GFR. Right? So we can use some substances. We can actually give you a substance called inulin, not insulin, inulin. Inulin, your body filters it, but it doesn't reabsorb it and doesn't secrete it. So what it pushes in here flows straight downstream unaltered. That's perfect because when we measure that, we can measure just how much blood is flowing through the kidney at any minute. That's called the GFR. So clearance in this situation gives us the chance to see what GFR, and you should be filtering about 125 milliliters of plasma every minute for a filtration rate. All right, well, what if I'm dumping something in here and then this guy is reabsorbing it? What's going to happen to the number of particles that make it downstream to the urine? They're going to be decreased. So in a product that is filtered but reabsorbed, the clearance rate is going to be lower than your GFR because if you dumped 125 pieces out here and you reabsorbed 60 of those, only 65 of them made it downstream. So my clearance would be 65. Urea is a good example of that. About half of your urea is reabsorbed into the body. About half leaves. So we could use urea to kind of guesstimate what's going on as far as reabsorption. Right? Another process is secretion. So what if I have a substance that's filtered, it's not reabsorbed, but it is secreted, which means my body hates this stuff, right? So it's downstream, and this guy, he hates that product, so he keeps throwing it out. Well, if I put 125 pieces in here, and 80 more pieces get pushed out here, what would this turn into? 205. Now my clearance rate is higher than my filtration rate. It lets me know if I'm actively secreting the way I should. There's a chemical called creatinine that's really good like this. Creatinine is actually creatine, which you learn about in muscles, but it's modified, broken down, and secreted into the bloodstream, and then you clear it through the kidney. So the kidney filters it, but the kidney doesn't like it so much, so it tries to secrete some of it too. So in that situation, creatinine kind of helps us understand, is the flow working appropriately and my secretion working appropriately? It's giving us an idea of whether the kidneys are appropriately working. In that situation, my clearance would be higher than my GFR. Right? So those are examples. Think about sugar, glucose. Glucose slips. Glucose gets dumped in here, about 125 milliliters in a minute. So what happens with sugar if none come out in the urine? It should all be reabsorbed. So what should my clearance rate be for sugar? It should be 0 because it's all reabsorbed. I shouldn't see sugar normally. So that's plasma clearance. It's giving me an estimate of what's going on, what mechanisms are working appropriately in the body. When you do tests, when you do testing, clinical testing, that's what they're actually doing. They do things like urinalysis and blood tests to see how efficiently the kidneys are working. All right, we can do urine dynamic tests to see how much flow you're putting out. Like, we can have you pee in a cup for 24 hours a day and see what's happening. We can have you urinate for a couple hours and see what's happening. We can measure your flow. After you get done peeing, we can measure with a ultrasound. We can measure how much urine's left in your bladder so you're clearing it efficiently. There's a lot of measurements that we can do to see if you're urinating appropriately. But these aren't really telling you what's going on with the filtration process. It's just telling you how much urine you're making. You can look. Can you actually see things? So we can take a scope and put it up in there. Can we see crystals in there? Or can we see ulcers in the wall? So we can do those kind of visualization tests. Heck, we can even look in your urine afterwards and see, are the crystals floating in the urine? And then here are two big ones, urinalysis and blood test. Urinalysis tests for that clearance and glomerular filtration rate. It uses a couple of chemicals, something called PAH, which is para-aminohippuric acid, which your body absolutely hates. So para-aminohippuric acid, when we give it to you, your body will filter it, and it hates it so much it will secrete the rest. What would you expect to happen to clearance? Would the clearance be higher than GFR, or would it be the same or lower? Well, if you filter it and you add more after filtration, it's going to be higher. It's about 625 milliliters a minute. Hates this stuff. So your kidney hates it and gets it out as fast as it possibly can. Well, the nice thing is that if we take this PAH, we can actually get a good estimate of exactly what's happening in the kidney. So on the high end of clearance, you're secreting plus you're filtering. We can look at something like creatinine and get another baseline measurement. We know on average, based on how tall you are, how heavy you are, whether you're male or female, how much exercise you have in a day, or roughly how much creatinine that you're making, and we can measure how efficiently your body gets it out. Then we can take a blood test and see how much is left in your body. So is your body secreting enough creatinine, or is it accumulating inside? So we can look at plasma concentration. And then the last one is blood urea nitrogen. And this is a tricky one, but cool. So remember last week when we were talking about the liver, and I said if the liver's failing, you start accumulating ammonia in your body. That ammonia goes to the brain and causes what disorder? Which is telling you the liver and the brain combined have a problem. It's called hepatic encephalopathy, right? So that ammonia goes up into the brain and starts causing lots of craziness in your brain, disruptions. It's because when you eat protein, that protein's broken down into little amino acids, and those amino acids are broken down small enough so that they're just a couple carbons in basically ammonia. Well, when you burn those as energy, the liver will normally clean up the ammonia and then push it out into the feces or modify it and turn it into urea, which we'll talk about in a second. So the liver takes care of it. If the liver's not working, you can't get rid of ammonia, so you see a rise in ammonia. But if the liver is working, it'll take that ammonia and it'll turn it into uric acid, urea. It turns it into urea. Well, now pushes the urea into your bloodstream, and it's the kidney's responsibility to get it. Ammonia is really toxic to your brain, but urea is not so toxic to your brain, not anywhere near compared to ammonia. But the problem is if you start accumulating urea in your bloodstream, uric acid, what's it start making? Gout. Yeah, uric acid crystals in your joints, which is gout. Those uric acid crystals can also accumulate in your kidneys, your bladder, and cause what? Kidney stones, which we'll talk about in just a bit. All right, so this blood urea nitrogen is important because it gives you an idea of are the kidneys working and is the liver doing its job? So if you have a buildup of ammonia and really low blood urea nitrogen, it means the kidneys are maybe fine, but your liver's not working, right? Because the liver's not converting ammonia into blood urea nitrogen. But if you have high blood urea nitrogen and very low urea in the actual urine itself, then you know the kidneys aren't clearing it efficiently. So that's kind of a tricky concept, but that's the whole baseline behind those tests. So homework number 2, what is creatinine? I kind of told you, but where does it come from? Don't write me a whole biochemical analysis of it. Just tell me, how do you get this creatinine into your blood? Right? So where does creatinine come from? What is it? And what other problem could actually raise your blood creatinine? So don't tell me the kidney failing. Give me another example. And I know we've talked about it in another section in this class, but do you remember? So give me a couple examples. If you have to Google it, I don't care. Look it up. But tell me, what are other problems that could make your creatinine rise, which makes you think maybe you have kidney failure, but you don't. And then what is the blood urea nitrogen level representing? I kind of already hinted at that, but I'm going to have you explain it to me. Remember, I don't want the biochemical analysis. I want you to be able to explain it to a lay person. So where does that blood urea nitrogen come from? Again, don't give me a biochemical analysis. Just tell me where it comes from. And if you want to explain how the liver is involved, that's fine. But just not super detailed. I just want you to understand, not give me biochemical analysis. And then what else could raise these blood urea nitrogen levels? What could lower them is another thing you might want to put in there. All right, question number 3. So question number 3, now that we've gone back and we've talked about some things like hormones, and we've talked about why the kidney clears and everything, tell me why these treatments are used. So now you're looking at the kidney issues overall. Right? So why is it we put people on a restricted diet? So restriction of dietary proteins. And don't tell me because proteins go straight to the kidney and then they make you urinate kidney, because that's crap. You should know when you bring in protein into your GI tract, you have to break it down to amino acids to bring it into your blood. Well, now they're in your blood as amino acids, not protein. So you would actually be peeing out amino acids, not protein. So why is it then that they make you restrict your protein? Right? Think about it. You can look it up if you need to. I actually kind of already answered it with the amino acids. If you don't remember, go back to the clearance section and review that. And then vitamin D supplements. Why do we give them vitamin D? Why do we give them something called synthetic erythropoietin? And then the last one, when somebody's kidneys are failing, why do they adjust the drug doses? They don't necessarily adjust the drug doses to save the kidney. They adjust the drug doses for another reason. Why do these people have to watch what kind of drugs they take from that point on? And you want to think about this with the elderly too. They have to watch their drug doses closely because of a problem that could happen with the kidney. All right, so the macroscopic structures. I'm not going to spend a ton of time on this because it's really the physiology I want you to understand, but the larger structures, you know the cortex, you know the medulla, here are the medullary pyramids, here you have the calyces, here you have the renal pelvis, and then the ureters going down to the bladder, and the bladder goes out through the urethra, and then outside the body. So think about those major structures. When we start talking about blockages like kidney stones, this is where you want to remember these different structures. Right? So blockage symptoms, if I block here, what happens to the fluid here? It backs up. I can't make as much urine. The pressure builds up in here and it starts destroying this tissue. Right? What if I block it up here? Well, then this area is fine, but up here in the medulla is problematic. So when you make blockages, a lot of times the symptoms will actually cause backup, lack of urine flow. You retain more water, which leads to things like hypertension. Okay? Uremia is actually a group of symptoms, and we'll talk about that later. It's not just high urea in the blood. It's a group of symptoms. And then flank pain. If you're building up fluids in the kidney starts causing this like excruciating pain. It helps you localize where the problem's at. Right? So if you have a blockage here and it's building up here, it causes kidney issues, kidney pain. Urinary tract, kind of already reviewed this. So out of the kidney, you have the ureters that are coming down. They go into the bladder. They actually come down here to the bottom back edge and come in. And then you store, this is all smooth muscle. As it stretches, gets bigger. It starts sending signals up to the spinal cord that sends signals back to help you release the sphincters down here. So you have the internal urethral sphincter. And that internal urethral sphincter is smooth muscle. Voluntary or involuntary? It's involuntary. So that starts relaxing. But luckily, your brain's intact, and it squeezes the external urethral sphincter, which is skeletal muscle, which keeps you holding your urine. Right? So when you look at this pathway, you can have structures that are blocking. You can have ulcers in this wall. You can have tightness of the muscles that restrict its ability to stretch. There are lots of problems that can happen. A lot of times with these, you'll feel the pain. If it's up in here, you feel the pain radiating to the lumbar or the flank regions. If it's down here, it's more the abdominal pelvic regions. Usually when you have damage in here, it's things like blockage or the inability to expand. So you see usually frequency issues, having to have to urinate a little bit more frequently. Okay? And then also the pain that I mentioned. Right? And then I guess I kind of covered this on the last one, but when the bladder and the urethra, any of those blockages, it makes you feel like you have a fullness of bladder because the fluid's building up, backing up, and You have to get rid of it really bad. Sometimes when these muscles don't stretch appropriately, it makes you feel like you have to pee more frequently. So you may be peeing the normal amount in a day, but you're doing it so frequently because your bladder can't expand. So again, feelings of fullness, and sometimes it can cause incontinence, because if it doesn't expand, then it'll be squeezed out whether you like it or not, and you dribble a little bit. Okay, so the last we're going to talk about in this section is renal aging. And really with renal aging, you want to just keep in mind elderly and infants. Infants, up until the time they were born, they were depending on what structure in between mom and baby to do all of the work of the kidney, basically. Well, not all of it, but a lot of the work of the kidney. Right, the placenta. So the placenta has been working as a kidney, it's been working as a GI tract, it's been working as everything up to this point. So the baby's kidneys aren't completely developed. They have weaker muscles like the sphincters. So some things you have to remember is that babies don't have as much control. They may leak constantly, well, I shouldn't say constantly, they may leak frequently. They don't have the neural connection from the brain coming down the sphincters, so they don't have that voluntary control like we do. It takes time to develop it. And because they don't have any, they don't have as much control over the sphincters, they actually have a higher risk of UTIs. So the UTIs can go up if they get into the bladder. They can go up and into the kidneys because the muscles aren't that strong to keep it out. So about 50% of infants with UTIs, or about 30% of older children, get something called a reflux disorder, where the bacteria can get up into the kidneys and cause damage. Right? And then, of course, since the kidneys aren't working efficiently, they have an increased risk of drug toxicity. And when we talked about this in the electrolyte section, it's also because they have less blood volume. So a little bit of drug actually is a huge percentage of their blood volume. So here's some other disorders that could actually happen. This is called horseshoe kidney, so it's congenital or genetic disorder, actually, I should say, where the kidneys fuse together and they look like one kidney. And here's another example. Those are two different kidneys that are actually fused together. And here you can see the ureters coming out and going down to the bladder. Here's the actual right renal fusion, or renal fusion, where the kidneys fused into one, and it's not even horseshoe, they're just completely one fused. You can see the two ureters coming out and going down. Here you can see more than one ureter coming out of the kidney. This is actually called nephroblastomatosis, and it's, well, just by the name, it's nephron tumors. So they're all over the place, and of course they can cause blockages and backup. So there's some congenital things that can happen. And then aging and renal function. As we age, we start with about 1.2 million nephrons per kidney, but as we age, we start losing them slowly, whether it's because of high blood pressure, just a natural process of aging. So our ability to filter or clean out things is reduced. It keeps going down lower and lower and lower. So you can see here, in a normal kidney, maybe you can excrete this must solute into your urine. See all those little green particles? But in an aged kidney, because you don't have as much vasculature in here and as many nephrons, you can see you can still make the urine, but the problem is you can't get rid of as many solutes. So think about that when it comes to drugs. As you're urinating out and you're trying to get rid of those drugs, your kidneys aren't working efficiently, those drugs can accumulate. So if you're taking the same dosages as somebody younger than you, they're peeing it out, but you're keeping it in, which is extremely dangerous. So they increase the risk for things like drug toxicity. All the things that you normally want to get out of your body, like acids and urea and things like that, they stay in the body. And if the urea stays behind, what's it potentially going to turn into in the joints? Uric acid crystals, right? So that explains why gout is more common as we get older. And you can even see the kidney itself in size decreases, but it's primarily because of this vasculature. And about every decade, we lose about 10% of our intrarenal vasculature. It just keeps going down, down, down. So, yeah, by the time you're 80, you've got about 20% of your function, which means that your kidneys aren't working so well, right? So they're more susceptible to things like dehydration too. So here's just kind of a review, things you want to keep in mind as you're remembering what the kidneys are controlling. So for instance, in a normal kidney, it's good at regulating sodium, water, wastes, hormones. In a dysfunctional kidney or a problematic kidney, you usually get fluid overload. You have elevated waste in the body because you can't clear them efficiently, and they're some of the ones that we look for. And then the same thing with the hormone levels. Right? So they don't change as easily. I'll see you in the next slides.